Well, hopefully you can hear me. I'm Dr. Duke Machen here with my team and Dr. Patel, and today we're going to be performing a lumbar fusion. You all know this is what's called a TLIF, TLIF. It's the most popular lumbar fusion technique. Just so you know, I was trained on this technique over 20 years ago. Luis, I don't know how many times I have to tell Oscar to stop tying up the cable. Same thing, over and over again. Anyway, thanks for interrupting our broadcast again, Oscar. So, 20 years ago, 25 years ago, I was trained in this technique. Most surgeons are just learning it now for the first time. This technology is over 25 years old. We've actually moved on to more advanced technologies, the Duke laser disc repair. This patient wanted a fusion, so we're doing it. She is in healthcare. She understands these surgeries. She's witnessed them in the past, so she knew what she wanted. And I don't force people to do any type of surgery. They choose what they want. As long as it's reasonable and safe and effective, I'll do it. So you guys are getting an opportunity to see a surgery that's actually quite popular. Not at Duke Spine anymore, but elsewhere. All right, keep your knuckles out of the view. So far we have exposed the spine. This is all part of what we call the exposure, where we're getting the spine, removing tissues above it that would prevent us from doing the surgery. Ultimately, we want to take the disc out because she's got two painful discs and pinch nerves. So we have to decompress the pinch nerve. She has a drop foot, and it's getting worse. The drop foot's on the right side. It wasn't there a few months ago, so it's clearly getting worse. And we're going to go unpinch those nerves, especially on the right side, but both sides. Suck, please. So this surgery really does a few things, three things to be exact: decompression, reconstruction or realignment, and then stabilization, which the fusion is and instrumentation are the stabilization. All right, I'm just going lateral now to the L3-4 facet, trying to preserve the facet capsule. Can you see that capsule right there, the white thing?
Yes, we can.
So because we're not fusing L3-4, and that's the L3-4 facet joint, I'm going to go lateral, and I'm going to try to preserve the joint but find the transverse process, which should be right here. You can see it right there. You feel it, Dr. Patel? Dr. Patel and I were just talking about the transverse processes earlier. There's the mammillary process right there, and there's the TP. You see it?
Yes, we do.
So we do a procedure nowadays called the Duke plasma rhizotomy to treat facet joint pain. Because people, look how arthritic her facet joint is. People get arthritis in their facet joint, and that causes back pain. It's responsible for about 15% of back pain. Facet joints are. And the technique I'm using right now was sort of the inspiration for doing the Duke plasma rhizotomy. And it's very effective at eliminating, this is fat, by the way, I'm trying to get rid of so I can see what we're doing down here. Getting rid of facet joint pain. All right, so this is the sacrum or tailbone, and this is all sacrum. Then you have the L5-S1 facet right there. Look at the overgrowth of the S1 superfacet wrapping around backwards and medially around the L5 inferior facet. All right. Actually, that may be 4-5, right? So that would be the 5 inferior, 4 superior. This being the L5-S1 right there. The L5-S1 pretty collapsed. Okay. So let's just verify one more time our levels. Okay, let's bring our x-ray in one more time. And then we're ready to get going on our bony removal. So this should be the L4 pedicle here. Let's go ahead, move out, out. Are we live streaming voice and video?
Yes, sir.
All right. We're also monitoring during this surgery the patients. You should be on the eye in the sky right now, and then fluoro. Bring the table up. I would take it off the first person and have eye in sky, third person.
Copy that.
All right, that's looking good. So it is the pedicle of 4. You could see it there. Okay, so we're in the right spot. Stay there for a second. I'm going to check one more pedicle. How about this here? This should be 5. It is. Very good. All right. Table down, floor out. You could also see, show us the screws in her sacrum. She's had an SI fusion, sacroiliac fusion, done. You guys see those bolts there? Henry?
Yes, we do.
All right, very good. So right off the bat, compared to the Duke laser disc repair, you can actually see, number 1, big incision with the fusions. Number 2, lots of damage to the muscles. And now we're going to start taking the bone out, okay? Luis, it's not, we have a full schedule today. It's not time. You guys see that movement there? Look at that. She's got good bone. This is L5-S1. I'm doing an L5 laminectomy. This is an L5 laminectomy. You guys wonder what laminectomies look like? This is it. Okay? It doesn't matter if you do it open or minimally invasive. It's removal of the lamina. It's very destructive. Unnecessary most of the time. The good news is we're going to take this bone and use it in the bone graft. Luis is going to clean it. It's got nice diploic bone. That's the red stuff. Okay, beautiful. That's the L5 lamina. Trying to save as much of this nice bone as we can to use it for the fusion. If you don't use the local bone from the patient, you have to use all kinds of synthetic stuff. There's a little bit of fat. You see that fat right there that Dr. Patel is pointing at? Just under the lamina. It's got great bone. That's a great sign. I'm going to start on the L4 lamina. Can you guys see this, Henry? I'm taking the L4 lamina out.
Yes, we can.
Her bone is strong. It's great to see. That means that the hardware that I put in will be good and strong and fixated well. It means that she'll probably fuse her spine nicely. Because fusion is not something the surgeons do. It's something the patients do. A lot of people don't know that. They say, oh, my spine was fused by the surgeon. No, we don't actually do fusion. We set it up to fuse by putting in screws, rods to hold everything together so that it will fuse. But the reality is the patient has to fuse their own bone. That's why there's such a thing as a failed fusion. It really means the patient didn't fuse. Fusion actually takes about 6 months to a year to happen. All right, so for me, I'm going to do my osteotomies because I really want to make sure that the foramen is totally decompressed. She's got lateral recess and foraminal stenosis. That's pinching her nerves here. So I'm going to do what's called an osteotomy. Smith-Peterson. And I actually published this technique years ago. If you look up my name, Duke Majan, and look up in PubMed, take it, you'll see, drill. You'll see that I published this technique, and what it does is it allows, number one, it allows us to get good lordosis, because she's got, if you look at the x-ray, let's go back to the x-ray. Can you see the x-ray, Henry?
Yes, we can.
All right, so you can actually see that where we're operating, the L4-5, L5-S1, it's straight. The spine is straight. And then you go above that, L4, and you can see curvature. So when you have degenerative disc disease, you lose your curve. Okay, you ready? So to get the curve back, I'm going to do an osteotomy. And look at the bony growth here. I want to show you this. Large bite. Come on, Luis. Luis, help him out. All right, you guys see this bone right here? That's not supposed to be there. Can you see this?
Yes, we can.
Right there, okay? That is overgrowth of the facet. There's the actual facet joint, and this bone is literally growing over like a wave. And that's showing the instability that's been going on. And her facet and her body are trying to stop the unstable movement by forming bone. So we're going to remove this abnormal facet. I'm performing what's called an osteotomy. And this is going to allow me to decompress the neural foramen, get the pressure off the nerves, because the nerves are getting crushed here. Cracker, you remembered. Once I make my osteotomy, see how it cracked nice? And then I'm coming into the joint space, and I'm going to lift this facet right out, okay? And I'm going to show it to you. It's enlarged. Yeah, you see that? That's not a normal facet, okay? Stuck down by ligaments that are hypertrophied. Take that. Oh, can you see this?
Yes, we can.
Pointer. So right here you can actually see the formation of osteophytes or bone spurs. These are not normal. These are in response to abnormal movement. Well, now we're going to take this nice little piece of bone, we're going to chop it up. Here you go, Luis. And we're going to basically put it back in to do the fusion. Large bite? All right, so I want to show you something else here. Pointer. I got it. Guys, see this yellow ligament right here? That's ligamentum flavum. See it? Okay?
Yes, we do.
That is going out into the foramen. You see how it goes out into the foramen? This becomes the foraminal ligament. The reason it's so thick, it's very thick. It's about 3 times to 5 times thicker than it should be. It's also getting thick and it's pushing on the nerves. It's one of the reasons people get stenosis or narrowing. And it's thick because her body is literally responding to the abnormal movement by making her ligaments thicker. Okay? This is where we're going to put the screw. You guys hear that snap? That is strong bone. It's wonderful to see. Bovie. Let's go. Come on, have the Bovie ready. And give that to Luis. All right. Okay, now I need the Woody and a large bite. I mean the Kerrison, sorry, Kerrison 5, Woody. All right. Now I'm going to protect the dura and the nerves as I remove this very thick ligamentum flavum. You guys see this here? Remember, none of this happens with endoscopic surgery. We would be done with the endoscopic surgery by now. Our patient would be getting ready to go home. So you can see how much more invasive fusions are. It doesn't matter if they're done minimally invasive or not. We're doing this outpatient, for those of you wondering. We're not at a hospital. We're at the Duke Spine Institute and the Surgery Center Vieira. This is the lateral recess right here. This is where nerves get pinched. I can feel the herniation below. Okay, the nerve gets pinched right between this facet that's enlarged and the ligament and the bulging disc. Now we remove the herniated disc. We leave the ligament and facet alone. And it takes care of the patient's leg pain because, please wipe. That's not the right way to wipe. I got to be able to see. I'm feeling the foramen right now. It feels better. It feels more open. Where the nerve is exiting, right here. I got to be able to see. You can feel the pedicle. Okay, so the reason we have to open down here, this is the L4-5 disc, I believe. Right, Patel? The reason I'm biting south is I'm going to bite right down to the pedicle. Because I've got to put in a cage here and do an interbody fusion. So we need to open this space up as much as we can. Number one, to decompress the nerve root. And number two, because we want to put in a big cage. I cannot get in. Any questions from our audience?
Yes, we have a question from Meowasaurus on YouTube. And they asked, dumb question, but what is the difference between a Bovie and a bipolar?
Come on, wipe please. Bovie releases electricity at the tip and it travels throughout the body and goes out of your body through what's called a grounding pad. The exit point creates a circuit through your body. A bipolar creates a local circuit between the tips. Take gel foam. Sucker. Come on, come on. Don't move. I'm going to be putting in some gel foam soaked in thrombin. And basically, I'm using it right here where the veins are. These are called epidural veins, and they do bleed. And the right treatment is gel foam soaked in thrombin. We're going to get them to be Bovie or bipolar later. Come on, guys. Stop sucking things out. And these should be wet, not dry. See how it stopped the bleeding nicely there? So venous bleeding around the disc, behind the disc from Batson's plexus is best controlled at this stage of the surgery with gel foam and thrombin. These are gel foam soaked in thrombin. Okay? Move. Pay attention, Oscar. As I'm coming out, move so you don't get hit. Take this. Take this. Woodson K5. All right. So both devices wipe. Bipolar and Bovie are hemostatic devices. Move. Their job is to stop bleeding. Suck here. Where's our blood pressure? All right, it's fine. Any other questions?
No current questions.
Stop spraying that water all over me, Oscar? I don't care. It's always wet. It's not a reason to spray the surgeon with water. Drill. Suck, please. And when you're drilling over the spine, you have to just be really careful to control the drill. Let me have a kerosene 3. Then a 4. Kerosene 4. So I've drilled down through this pars interarticularis. Okay, and you can see the thickened ligament in the foramen. I've got my Woodson protecting the nerve roots drill. And I'm drilling through the superficial half and the middle. You just have to be super careful not to let your drill bit go where you don't want it to. All right, Cracker, please don't do that, Dr. Patel. All right, there we go. So I've just osteotomized the second inferior facet. Take this. And again, it's stuck in here. Here's the thing, if you don't do these osteotomies, mallet, then what's going to happen is you're not going to get correction of the deformity. I see all these big time spine surgeons doing these surgeries and they're not doing the osteotomy. And there's some of the smart ones are. They're figuring it out. I've been doing it for 20 years. But if you don't take this abnormal facet out, then you're not going to get any correction of deformity. The patient's still going to have a flat back because this is not moving. Do you guys see that? I'm literally leveraging tremendous force just to get it out. And it's already released from the other bone. It's just ligaments and soft tissues holding it. So take this. Okay, totally ruined from arthritis, the joint surface. It's supposed to be cartilage here. It's supposed to have a synovial capsule with liquid in there. All that's gone. You got bone spurs. You guys see the bone spurs here?
Yes, we do.
Yeah. Give that to Luis, please. All right, so not only have we now decompressed the nerves, which we want, that's the side she had her drop foot, but we've also allowed for correction of her deformity. She's got a straightening of her spine at L4-5, L5-S1. So if you're going to fuse somebody, you might as well fix their alignment and get their alignment good and get them into a lordosis. You want a nice curve. So I always go for maximum curvature. The biggest problem in degenerative spine conditions is the spine angles forward. You want to curve it back. The lumbar spine needs to be curved backwards. So I see a lot of spine surgeons fusing patients straight. They don't correct the deformity. Well, what's the point? I mean, you're going to fuse them and they're going to develop adjacent segment disease. Their disc above and below are going to go bad. They come back for more surgery. With Duke Spine Institute, our fusion patients, they come back for a second surgery, a second fusion, 1%. Only 1%. That's because we do it right the first time. All right. A lot of spine surgeons move. They only want to do one level at a time. All right. Let's have a large bite. And they want to just keep bringing the patients back so they can make more money on them. We don't. We want to fix them right the first time. That's our philosophy. Drill. So I'm going to open this foramen up because I'm going to take the top half of this superior facet out. It's digging into the nerve root. Again, you have to have full control over the drill because you're drilling next to nerves. You don't want to accidentally hit the nerves and you get a spinal fluid leak and a nerve damage. It's a big problem. All right, kerosene 5 or 4, either one. So you see how I amputated the tip of this hypertrophied spinous process? Superior facet out. Not spinous process, superior facet. All right, there we go. Now, that thing was actually digging into the nerve. This was shoving up against the nerve that's exiting. Gel foam. Okay, I feel the bottom of the pedicle there. Feel the top of the pedicle there. So I want to put a little bit of gel foam soaked in thrombin. This is great for stopping vein bleeding. And we just load it up into this foramen. It doesn't do any damage to the nerves, and it just nicely stops bleeding. I see a lot of surgeons trying to coagulate down there or get a bipolar or a bovie down there. It's dangerous. You don't want to do that unless you can see perfectly well. Little vein, a little artery and vein right there, bipolar. So I'll use the bipolar right now to show you how it works. Bipolars are great for targeted bleeding, and you just get that little vessel between the tip and you turn on the electricity and it just cooks between the tips. You see that? How it does a little cooking there? The nice thing about the bipolar is it gives you great control, whereas the bovie releases a lot more energy and it just travels to far off places that you may not want it to. Okay, bovie. So I'm going to finish cleaning the soft tissue right here off of the pars laterally. Here we go, right there. I'm going to osteotomize across there and do the same thing here. Any questions?
Yes, we have a few questions. This first one comes from Sherry on Facebook. And they ask, is this person under general anesthesia?
Yes, this surgery is always done under general anesthesia. Come on, large bite. This patient is intubated. They have a tube down their throat. We have an anesthesiologist here who's monitoring them, and they're very stable. Drew? I'm going to put my Woodson out the foramen, protecting the dura. I'm going to make another osteotomy right here. Yep, you can't do this kind of surgery without general anesthesia. No human being alive could take the pain of this surgery. And let me tell you something, thank you, it's not just painful now, it's painful afterwards. Horrible pain. These people have massive pain after fusions. That's why they're in the hospital for so long. Mallet. Now we do it outpatient because we can do it safely and effectively outpatient. Okay? Yep. Large bite. Look how stuck that facet was. Do you think I'm going to be able to tilt the spine back with that thing? I mean, it's like cemented in there. It's like cemented in there. So these doctors that are doing fusions without osteotomies are really doing the patient a disservice because they're not putting the curvature back in the spine like it should be. Come on, man. Grab it and wipe. If you're not wiping, and the tissue's not coming out. Wait. Nope. Let me see. Obviously, I don't need to tell you this either, but the risks of complications are much higher with open back surgery like this. With the Duke laser disc repair, we lose about 2 mils of blood loss, 2 ml, which is like 40 drops. With this surgery, we're losing about 50 to 100 mils on average. And that's with really good blood loss control that we have at Duke Spine. Most surgeons will lose 500 mils with this type of surgery to 1,000. 500 to 1,000. But we use really good technique, and We use the most advanced hemostatic agents, kerosene 5. And I'm very fast. Most spine surgeons would take 5-6 hours to do this kind of surgery. Maybe 8 hours. We're going to have it done in 3 hours. Because I know exactly what to do. We're prepared. We actually have all the right equipment. When you have all the right materials to do good surgery, then the surgery goes much better for the patient. I got to admit, these instruments I'm using require a lot of strength by the surgeon. And I'm kind of weak right now because I haven't used them in a long time. I mean, I don't do a lot of fusions anymore. So my forearms are getting a workout. See the thickened ligament right here? Pretty cool, huh? By the way, in case you're wondering, please don't flick the water around. You can feel the nerve getting pinched. That's what I'm using. So I use my Woodson for the surgeons out there. I'm using my Woodson, which is this tool here, to feel the hole where the nerve goes, but also to push the nerves over so I don't rip them or tear them or damage them. Okay, so I'm using it for two purposes. To me, if you're going to do open back surgery, this is the most important tool, Woodson. See the nerve root right there, Suck? That's the L5 nerve root right there, the left L5 root. And I'm right above it, and I can feel it's being crushed. So, just working away here. Suck, please. Yeah. This all needs to be removed. Any questions?
Yes, we have a question from Bethany on Facebook.
Wow. Give me the osteotome again. Yes, Bethany. Mallet? Cobb?
They asked, how does the recovery from fusion differ from DLDR? Are strong pain relievers required for the DLDR?
Yeah, great question. So the Duke laser disc repair, we'll show you the Duke laser disc repair in just a minute. We don't require any painkillers for the Duke laser disc repair. Patients take Tylenol. That's part of the facet. They don't require narcotics with Duke laser disc repair. This patient will take narcotics for 6 weeks after surgery, and that's with good surgery. Many of these patients with other surgeons will be on narcotics for a year or two afterwards. But at Duke Spine, our patients do exceptionally well with fusions because of our technique. Woody? So even with the best technique, please don't suck on the dura right there. Even with the best technique, which we provide, you're still on pain pills for a long time. Those are opioids, dangerous opioids. Everybody knows about opioids. We don't like using them, but you have to use them for fusions. There's no doctor in the world that can get away from using opioids. Not even us. We try not to use opioids the best we can, but it's absolutely necessary for this kind of surgery. All right, you can see we're making progress. This is the lateral recess, okay? Very important area of the spine. It's the most common area where nerves get pinched. Okay, the pedicle is right here. The lateral recess is just medial to the pedicle under the facet. You guys see that? It's the number one place nerves get pinched. It's the one place radiologists, they never talk about. They rarely talk about the lateral recess because most of them look at the central, this area, and they look at the foramen, and they ignore the lateral recess. And that's the most important place to look for stenosis. People that have symptomatic stenosis, it's from lateral recess stenosis almost every single time. All right. Let's show our audience how does a herniated disc actually cause back pain. Suck, please. See the 5 root? Your sucker's in my line of sight.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. So, hopefully you've seen why herniated disc actually cause back pain. Very common problem. And now we'll show you the best way to treat a herniated disc. Harrison 4. Why don't you show our video on how does the Duke laser disc repair work?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. You've now seen what the Duke laser disc repair is all about. Suck here. Yep. Good. All right. We're just about done. We've done our osteotomy, left L4, right L4, left L5-S1. Now we're going to do right L5-S1 suction. And we're going to be done with our osteotomy. Kerrison 5. So, for those of you wondering what this thing is, this right here is all the nerves. It's called the thecal sac. That's where the nerves are. I want you to look at it. Irrigation. Don't suck and scrape because you could have sharp ends. Suck. All right, you guys see it? Look at it carefully. Look at this. All this stuff on here is scarring, scar tissue. The reason it's scarred is from the facet joints. Tremendous amount of facet joint arthritis. Okay? So the facet joints have inflammation and they scar the thecal sac. All right, large bite. Drill. Don't try this at home. Any questions?
Yes, we have a few questions. This first one comes from John on YouTube, and they said that looks extremely painful and damaging. If I start showing signs of spinal cord compression, I'll go ahead and pay for the DLDR out of pocket instead of having a That's a fair doc limit me.
Yeah, thanks, John. It's true. That's why we do the DLDRs. This is so damn aggressive and damaging. But this is the, you hear about TLIFs being done all over the place. And like I said, I learned how to do TLIFs 25 years ago because we were at the cutting edge at my neurosurgery training program, and we were doing the best TLIFs. But when you compare, Drew, when you compare this, which is the best TLIF you can get, to DLDR, my God, it's just so obvious the amount of destruction with this surgery and the risk. Look at the risk. I mean, I hate to just say it, but I'm drilling on the nerve roots right here. It's very concerning. I've never had an injury, Kerrison 5, but these are the nerve roots right there. Look at where we're drilling. The nerve root is exiting right here, and I got to drill above it to decompress it. None of this is necessary with the DLDR because we're doing the decompression from the front rather than from the back. We're going and taking the herniation out from the side of the spine. We come around the side, which is really the front. So, yeah, I agree with you. It's pretty brutal.
We have another question.
Sure.
This comes from Best Sports Media TV on YouTube.
Let me have a kerosene port.
And they asked, I'm no surgeon, but I'm curious, why is the room so dark?
That's a great question. To save on electricity, our electric bill is $10,000 to $12,000 a month. I'm just kidding. That is our electric bill, by the way, but it's not to save on electricity. It's really to allow the focus and attention to be right here on the patient, and I guess, I don't know, maybe it's to help with the video. It's a good question. I don't have a great answer for you, but I like it this way. It cuts out the distractions and light, in other areas. Is there something you wanted to see? Let's have a drill. We tour you on the operating room, but we don't want you to see the patient name, so we kind of stay focused on this area. But it's pretty standard for ORs to have all the light really right here where the surgery is. Let's have a cracker. So you see the facet has been already osteotomized, and I'm going to remove it. And I feel like we've gotten really good decompression on the right side and left side. Remember, she has a drop foot now, which she didn't have a year ago, so she's clearly getting worse. And we want to make sure, take this, that we got all the pressure. Here's a Bovie, by the way. Somebody was asking difference between Bovie and bipolar. This is a perfect Bovie job right here. I ripped that little bone out, and it was attached to the soft tissue laterally, and it clearly tore a little vein. So I'm using this Bovie to, cook the veins and close them by cooking them. Anyway, you wonder why these surgeries hurt so bad afterwards. You can see a lot of trauma to the soft tissues. Unavoidable, okay? Now, people will talk about minimally invasive, right? Kerrison 5. But what I found is that we can do a better job of preserving the integrity of the soft tissues and reducing postoperative pain by doing an open surgery rather than a minimally invasive. Come on, guys. What was that?
Tell me which number it is.
Oscar. Tell me which number it is. Your job is to protect those instruments. All right, that's good. We need gel foam. Any other questions?
Yes, we have a question from Mohammed on YouTube.
Hello, Mohammed.
And they ask, it looks so deep. Where is the spinal nerve root?
Suck, suck, suck. Come on. Where is the spinal nerve root? Well, I'm going to show it to you in a moment, okay, Mohammed? These are the nerves right here. This is the thecal sac. You see it? It's got all the nerves in there. Irrigation. Now, let me just tell you what we've done so far. Come on, you clog. You can't see that? Oscar just dropped the irrigator. Anyway, when the surgeries are easy like this, my staff decide to challenge me and make my surgery hard for me. Okay, we've done our exposure, we've done our decompressive laminectomy, we've done our osteotomies called Smith-Peterson. I still have a little bit more to do on the osteotomy. I'm about to do it. And right now I'm going to remove the gel foam that isn't wipe in the foramen at L4-5. Suction, okay. Bipolar. So you see the veins down here? They're just underneath the nerve root. So now that we're ready to start our inner body work where we take the disc out, I'm going to bipolar these veins like I am now. You're seeing it? They're literally sitting on the back of the herniation. I'm going to show you the herniation in a moment. So the important thing is to be in the bottom half of the foramen where the herniation is. That's what I'm doing. So I'm cooking these veins with the bipolar scissor. And next I'm going to cut them with the scissor. Okay. Wipe tips. So I'm going to use a special micro scissor to... Huh? I can't hear you. Yeah, of course. We're in the discectomy. We're about to start. Yeah, that's what I'm saying. We've done our exposure. We've done the osteotomy. We've done the laminectomy. Now we're going to... How's the blood pressure? All right. The key to the bipolar, folks, can you guys see what I'm doing here, Henry?
Yes, we can.
Yeah, the key is if your tips are dirty, it stops working. And the way they get dirty, they don't get dirty with like grass and stuff. Yeah. They get dirty with blood. Gel foam thrombin. Where the disc is a little lower, Dr. Patel. You see it bulging out there? Yeah. Good. Don't move. Don't move. When you move, you make it a moving target. You understand? Yes, sir. Makes it a lot harder for me. All right. So, for disc that I want to remove, L4-5 is right here. I got to still clean a little bit of this stuff out. Kerosene 3, take, protect the nerves. I'm going to show you the nerve root in just a moment. Move your hand. Yeah, drill. I'm going to take down a little more of that facet that's still there. This is the pedicle, by the way. That's where the screw is going to go. You can see it very nicely. Okay, kerosene 3, irrigation. Come on. So we call it bone dust. So you see how I've taken the thick part of the bone down, left a little shelf with ligament that I need to remove. Okay, what we've got here is the herniation. Bipolar, little bit of veins. Look how scarred the veins are. These are scarred veins from all the inflammation from the herniation and from the facets. They're scarred. These are not what normal veins look like. Okay. Gel foam. bipolar is the perfect tool. Now, there are lots of different kinds of bipolars. I use what I think is the very best in the world. It's called a Roten. Let me have the cutter, scissor. The Roten bipolar. It's designed by Dr. Albert Roten, one of the top neurosurgeons in the world, one of my instructors and faculty. Jofum. All right, this is the Roten bipolar. It's the very best you can get. I've tried them all. All the vendors try to get you to buy their bipolars. And there's literally 100 different bipolars out there, but this is the very best. They're also the most expensive, but I don't care about the cost. I care about the quality. I want to have the best for my patients. All right. Now, right here is the herniation. You guys see that? Look at that big vein. Okay, so the veins in the back of the disc, I've taken them with the bipolar and scissor. Dr. Patel is retracting the nerve root. That's going to be the L5 nerve root that he's retracting. Okay, the L5 nerve root comes here and goes down around the L5 pedicle. We're ready to do our discectomy. So I need a 15 blade. Okay, we're going to cut into the disc. Protect. Don't get your fingers near the tip. This is mounted wrong, I think. It's very strange. It's like curved backwards.
What is it? The blade holder?
Yeah. Normally straight, somehow bent. Are you protecting? Give me a little more protection. Okay, that's good. So I'm cutting into the back of the disc. This is called the annulus fibrosus. You can see the bulging disc there. Now we're going to take out this herniation and the annulus. We're actually going to take the whole, as much of the disc out as we can. This is very different than the Duke laser disc repair. With the Duke laser disc repair, we use a laser to remove all this stuff and clean. I need the 3 rotator. Now I'm going to shave the disc out with a rotating shaver. 3, come on, 3 or 4. I don't need a 6. Luis, you know from the pre-op MRI, these are collapsed disc space. You should have the smaller rotating shaver available, ready to go. All right, what do you got, Luis? Give me the goddamn 6. You should look at the MRI ahead of time and see how collapsed the disc is, so that you're prepared. Okay? Suck, please.
Where is this material that
All right. So this is called a rotating shaver. It's going to remove the disc, the entire disc. It literally twists and shaves it off the end plates. There's not much disc left here, but the disc that's left, we need to get it out. Otherwise, there won't be an inner body fusion. We're going for what's called an inner body fusion, where we're trying to fuse the spine in the front between the vertebral bodies, called inner body. This is all disc material. You guys see it? Henry?
Yes, we do. Yes, we do.
Okay. You can't have a fusion as long as this stuff is in there. So TLIF, TLIF, transforaminal bipolar lumbar interbody fusion, bipolar, is a surgery where you remove the whole disc and do an interbody fusion. I'm going to show you what that is in a moment. Move your sucker south. Now every step you see me take has been literally developed by me over the years. Okay, so obviously taking the disc material out, that's standard. Everybody should do that or does it. Kerrison 3. But this is a step that I developed right here, Kerrison 4. And I'm going to tell you why. Because you get osteophytes at the back here and thick soft tissues, they prevent you from putting the right size cage in. So by doing this maneuver here, you're opening the back of the disc up to put the biggest cage in possible. And the biggest cage is what you want. Toe in. Perfect, right there, nice. Dr. Patel is protecting the nerve root, the L5 shoulder right there. Look how I'm biting medially. I'm trying to get as much of this disc material out as possible, okay? So I use the rotating shaver, I use the kerosene. There we go, beautiful view. Now I'll take the 8, actually near the bipolar. So what's bleeding into the disc right here is this vein. So I'm gonna try to bipolar it. Come on, man, hand me the bipolar properly. Did Luis not tell you knees up? Huh? I asked you a question, Oscar. Did Luis not tell you knees up? Alright, then do it. Don't hand me the bipolar improperly. What is this, 8? Alright, so now we're going with a bigger shaver. Suck, please. Aiming medially. We're going to use a short cage. You guys have short cage? What's your shortest? Shortest. Not talking about height. Yeah, that's your shortest. What are the other sizes available? Yeah, I want a 22. Your smallest one. Your shortest one. I don't know the height yet. I'm going to tell you the height in a moment. All right, so we did a 6 and an 8. Let's do an 8 again. All right, and if I get a good 8 turn, I'm going to go to a 10. Okay, you ready? So, I'm trying to go as far anterior without, that's good. Take that, grab her, pituitary. So I'm going to try a 10. The thing about the size of the cage, you want the biggest cage safely you can put in. And there's some tricks. Opening up the hole here is the most important. And then you want the tallest cage because that's going to give you the most correction of deformity. Kerosene 4. Take. Okay, you're pushing down on the dura. Barat. You're not under it. You're on top of it. You don't see that? You got to be watching. Okay. All right. So, biting this medial annulus, which is really hard and it limits the amount of cage, height of the cage. That's important. All right, I'm going to try a 10. Typically, the cage I put with the AlphaTech product is going to be 4 millimeters bigger than my biggest twisty, my biggest rotating shaver. You got to be careful hammering this in. You don't want to go into the abdomen. That's suck, please. You want it sunk all the way. I don't know that I can get this. I can't get this. Well, all right, so the other factor is the patient's bone quality. All right, so that is a 10. I got it. Pituitary. So I would say normally 10, 11, 12, 13, 14. 14, but let's do 13. Because 13's I think a lucky number. I'm kidding, but I don't feel like I got the 14 easily, so I want to go with a 13 cage. Okay. I think 13 is going to be the maximum size we can get in here. Now I want to check all my walls, make sure everything is open and ready to go. Okay, now I'm going to put some bone graft in because I've cleaned out as much of the disc as I can. And now we're going to put in bone graft. Huh? I'm sorry, I can't understand what you're saying. Oh yeah, the rasp. I apologize, thank you. So we're going to file down the end plates with this file. We call it a rasp. And really this is to help get the fusion going. Getting rid of any additional cartilage or anything that's in there. You want to control it. Look how I use this hand to control it, my left hand. My left hand basically prevents the tools from going in too far. I'm grabbing it and holding it. My right hand pushes down, my left hand controls the depth. It's a safety valve. Then I want to irrigate out the little pieces of, what do you call it, cartilage that you're just scraped off. There really is none left. Then I'm going to put in demineralized bone matrix, or DBM. Basically, bone graft. It's osteoinductive, osteoconductive. It's not structural, but it helps fusions happen. Then I'm going to put in morselized autograft that I harvested locally, basically from the laminectomy. Remember we did earlier in the osteotomy? We're putting that in. I try to pack it towards the middle, back middle. A lot of surgeons put in BMP. I don't use BMP anymore. It's unnecessary, it's dangerous. Produced by Medtronic, bone morphogenic protein. Okay, ready. I stopped using it like 13 years ago. Problem with BMP, a lot of patients don't know they're getting it, but it can actually eat your bone away. Literally dissolves your bone. Take your time, Luis. And when you look at the CAT scan afterwards, the bone is literally gone. It's a complication. It's bad. You're not supposed to eat bone away, you're supposed to make bone. So for some reason it eats bone away. People say that's because you high concentration used. But lots of surgeons have that problem. It's just not worth the risk to me. Irrigation. So I'm going to lubricate things a little bit with some irrigation. The dura is looking a little crusty. Okay, remember the nerves are in there. Okay, so nice and lubricated, keep things moist. And here we go. This is the cage. It's 22 milliliters long. It's 13 millimeters tall. Okay, it's filled with bone graft so that we can get a fusion in between. I'm going to do my best to get this thing in. Ready? And here we go. It's important to push down with your left hand as you're going in. I can't see. Okay, good. You want it countersunk, deep. You want it in there. Okay? You can actually feel when it's in the right position. And then you use a special tool called a tamp. Okay, so you can actually see what you're doing. And you want to advance it a little further anteriorly. Careful, very cautious. Let's look. That looks really good. I'm happy with that. That's all the way at the front of the disc where you want it. That way it counter levers you backwards like a seesaw so that your spine gives lordosis. Again, all these little strategies I use to enhance good alignment. The osteotomies, the anterior position of the cage. Beautiful. Come out. We're done. So we're done with the inner body fusion, inner body cage, osteotomy at L4-5. Now we're going to go to L5-S1. Again, this is a TLIF. It stands for transforaminal lumbar inner body fusion. So taking the gel foam out so I can get the bipolar in here and start bipolaring these veins. Okay? Nice job. Easy, easy. Look at all the scarred veins. Those are abnormal scarred veins from chronic inflammation. Now the nerve root is in there too, so we got to be careful. Okay, that's going to be your left L5 nerve root. So I'm staying below it. The nerve root's going to be right under there. I'm staying below it towards the feet. And I'm going to cut these veins so I can get down to the disc. Let's see, Dr. Patel. Let's see, gentle, gentle. Come on, man, stop handing me upside down. Last time I'm going to warn you. You won't be in the next case if you don't do it right. I don't know what you're doing. I don't need you making my surgeries harder than they already are. Pay attention. Scissors. Okay. So you got to put these in my hand so I can use it. Come on. Yep. All right. So this, relax for a second. This is your left L5 nerve root. Right there. You guys see it? Show it to them, please. See the nerve root right here, guys? Right there. That's the dorsal root ganglion right there. We're underneath the nerve root. There's really no space here to work. No space at all. This is pretty bad. I can't. Relax. I can't see here. I need to see here. Okay. Wow, that's your disc. Gel foam. So we're going to need to go further south to get the disc. I'm just getting hemostasis. I'm going to put some gel foam in here to help us. And a cotton. The cotton's purpose is so that we can suck on the cotton, not the gel foam. You don't want to suck on gel foam, it'll just come up and out. You don't want it up and out. All right, I need to open this a little more, Bada. I need you sucking here, okay? Sucking there. Not there, there, on the cotton. Okay, I need a Woody. Take this, come on. Let's see that MRI. Move your body, please, so I can see the MRI. It's pretty collapsed, too, at 5'1". All right. Here. Suck. Come on. Luis, get over here. This sucker is not working. Hold this. Hold the tube. See that. Show me here. Show me here. I need to feel. That feels like the pedicle of S1. Boy, this is just so bad right here. Yeah, it's too collapsed.
We have 3 and 4 at this time if you need it.
Huh?
We have 3 and 4 if you need it.
Right. I'm just wondering if we're able to get into that space. I need you to retract here, Bada. Yeah. Suck. Good. Yep. There you go. All right. Show me. I need to see the disc space. There. Not too hard. Not too hard. Here's the pedicle. You can see the S1 nerve root. Don't retract so hard. Let me have a Kerrison. Damn, there's no space there. We may not be able to get a cage in here. Take this. You can see the S1 nerve root and the L5 nerve root. No, yeah, fine. Let me see if I can make some room. Drill. I'm going to try to get in between these two nerve roots, but they're unusually close together. Kind of an anomaly. And if they're that close and I have to get a cage in, I may not be able to do that. So this is one of those things you just don't know until irrigation, until you get in. I don't think it's going to affect our outcomes. We'll still have a good result. But look, see the S1? Let me have a pointer. Okay, you guys see the L5 root, right? Henry?
Yes, we
Right
do.
there, that big thick thing. That's the L5 nerve root. The S1 nerve root, relax a little bit, it's right there. I don't think we can get it. We're just going to have to put a screw in. Let's see the Woody. Kerrison 3. Yeah, there's no space. So we're probably going to end up not doing inner body at 5'1" and just doing a posterior fusion. She's got really good hard bone, so we should be fine. Yeah. I don't see space. Let's see a 15 blade. Come on. This is the disc. Suck, please. There's just no space. It's totally collapsed. It's gotten worse since her MRI. Yeah. All right. Relax. Gel foam. Gel foam. All right. So we're going to just fuse this in the back. Good. Let's get that out. Take that. All right. Well, we've got all the nerves on pinch beautifully. And now we're going to start our screws. How are we doing over there? Good? No bleeding? So far we've had probably, I don't know, 50 cc's?
Do you want to put some
Maybe.
DBM there?
Huh?
No. Do you want to put some bone there, DBM?
No, I just did. I just roughed it up a little bit, but we don't need DBM. All right, we're going to put our screws in now. So let me just see. I want to check our screw entry points. Cobb. Cobb. Take that. Don't lose that. All right, I'm going to move these retractors around a little bit. We're done with the kerosins. You should be able to move those. Luis, let's move the kerosins out of the active field. Now, you can see we're working in a bit of a tight space here. Even though we're doing open spine surgery, not minimally invasive fusion here, you can still see there's not that much room. The hardest one to get is always going to be the top, right here. That's the entry point for our screw, right there, right there. Then the other one here, show me. Suck it, please, suck the top. Yep, right there. And then the S1 is going to be down here, like right around here. Yep. And then let's look at your side. Here. Bovie. A lot of fat there. Come on. So we need to open this up a little bit. So watch your sucker. That should be the transverse process. How's the patient, doctor? Doing well? There's the transverse process right there. Okay, just lateral to the facet. You got to be careful when doing this. You don't want to accidentally bovie the nerve. But there's the TP. Our screw, suck please. Our screw entry point's going to be right there, right here. Okay. Let's go to the next one, number 5. Suck the back. Right there, that's our screw entry point. And then S1, suck here. Suck here. That'll be our screw entry point. All right, we're ready. So I've identified my screw entry points. Now we're going to bring the fluoro in. Everyone's going to need step-ups. All need step-up. Henry, any questions while we're getting ready to put screws in?
Yes, we have a question from Bethany once more on Facebook. And they ask, is it common to use disc-based retractor to expand the disc before placing the cage?
I need my drill pedal over there, right at the top corner. That's not the drill pedal. The black one is the drill pedal. Table up, please. Come on, guys, get the fluoro in. What are we waiting for? All right, the question once again, Henry. Watch your head.
Question comes from Bethany once more on Facebook, and they ask, is it common to use a disc-based retractor to expand the disc before placing the cage?
I think Bethany's talking about cervical spine or anterior lumbar. We don't do that with a TLIF. So just what you saw is the best technique for a TLIF, which is a posterior lumbar approach. Remember, it depends on whether you're operating on the cervical or lumbar, whether you're going anterior or posterior, or lateral or oblique lateral. There are so many approaches, but for a TLIF, there's no use of an inner body distractor. Now, I want to zoom in, and that looks really good. You've got great WAG on 4. We're going to start with 4. Show me. Table up or fluoro down if you can. Shot. All right, that looks really good. Actually, you just corrected the orbital problem as well, so we're perfect. You can see the L4 pedicles. Show us the L4 pedicles. That's the first ones we're going to put our screws in. Lock everything down. Let's get the lights in. Lights in. Dr. Berndes, that's you. Lights in. That's good, that's good. Leave it alone. All right. All right, good. And this one, did anybody touch this? Is it still sterile? Yeah. Good, all right. All right, folks. We're going to put our screws in at this point. And I need to get in here. I need to see right here. There's the mammillary process, the entry point. That's where you're supposed to put your screw. Shot, irrigation. Shot, perfect. So that's right where we want to be. Okay. So now that I've gone through the cortex, thank you, I need the gear shift, mallet. So I'm going to use this gear shift to, I need you sucking. Yep, right there, perfect. All right, let's get a shot. Where are we at? Perfect. So I'm going to gently let this thing find its way. Okay. And I want to aim medially. Shot. Now we're putting our screws in, so monitor the EMG. Okay, waveforms. Tell me if you see anything. Suck. Do you have a different gear shift, or is this the only one you got? It's not bad, but I'm just wondering what other options we have. So now we're into the vertebral body. Okay. She's got really narrow pedicles. You don't need to do that yet, Luis. Well, it's distracting. Yeah, I'd prefer you not do that till we're done. Okay, stay focused on this. This is, we're going to have to do a 6-5 screw probably. Mm-hmm. Shot. Right there is a 35. Right there should be 40. Let's do a 6-5 40. Yeah, let's have a 5-5 tap. Take that. Give me the tap, please. That's a big tap. Is that really a 5-5 tap? Wow. Shot. All right. So we've drilled through the cortex, and we're now tapping. It's a very aggressive tap. And it's under tapping because I'm putting a 6-5 diameter screw. I'm going to under tap at 5-5. Okay? So that way the screw is a bigger diameter than the tap. I need a ball tip probe. I'm going to sound the pedicle. I want to make sure we haven't breached. Take. Feels good all the way around. So what I'm feeling for with this little shot, yeah. So what I'm feeling for is that the pedicle should be bone all the way around. So I'm feeling with the ball tip to make sure it is. And I don't feel any muscle. I don't feel like we've breached out. Feels good to me. Shot. So far, so good. How's our stream? Not you guys. I'm asking Henry.
Stream is going good. We do have a question.
Yeah, give me a minute. So the purchase, listen to the purchase. You guys hear that? It's like a snap. That means that there's nice compression of the screw by the bone. It means that there's really good purchase. Shot? Now if you put the screw in too far, then you lose the polyaxial head, which you don't want to do. So you got to put it in just the right amount so the head moves, okay, and stays polyaxial. Polyaxial, let's go irrigation for the Dura. Polyaxial means that the head of that screw can move around and can take a rod anywhere you put it, basically. Next, Cobb, let's go your side, Baran. Cobb. Come on, I need you to do this, man. I need your help here. I need you to suck this blood here. Okay, that's what you got to do to help me. I got to get my drill in here. All right, let's get a shot there. That looks pretty good. That looks pretty good. Suck, please. Come on, Bada, I need you to suck the blood. That's right. That's where you should be. Looking over the edge. You're blocking my view. All right. Pedicle finder. Let's go. Gear shift. Take that. Shot. All right, that looks pretty good. I'm gonna aim medial. I'm aiming towards the midline. You want your screws to come together in the midline. Shot. Now there's many ways to put screws in. There's no one way that's right, but me, I like long screws, and I like them in the pedicles as much as possible. Sometimes you're going to get breach. As long as the screw is strong, it's okay. It's not the end of the world. The last one was a 40. There's someone who might be able to get a 45. Let's do a 6.5 45. This pedicle's a little different. Tap, suck. Quickly. Luis, get over here. He doesn't know what he's doing. What do you think I need after I did the gear shift? You're supposed to reset this. Yeah. All right. Shot. Going in nicely. Shot. I mean, it feels good to me. And I feel bone all the way around. Shot. So again, I'm aiming medially. Shot, and I'm using the X-ray to take pictures along the way and make sure the trajectory is looking good. I feel really good compression on the screw. You can hear it too. It's chirping. We call it chirping. Those are the hardest screws to get in, by the way. And that is your shot. That's your your top screws. I cannot disengage this. It's pretty tight. Oh. All right. Great. Okay. Next one. We need to line that up properly on X-ray. So let's get the wag fixed. Let's drop the table 1.5 inches. More. Good shot. No, you went wagging the wrong way. You can see the top screws look great. We're able to get about 5 or 6 degrees of correction of lordosis. I can't see that pedicle well. I need you to fix it. You're off by about 1 degree, and you're off on orbit. You're off on orbit 1 degree, you're off on wag 1 degree. You may be off more than that on wag. That looks worse. The orbit's okay, but actually the orbit may be worse. I think the orbit was worse. That looks, what do you think, Bharat? Better? I mean, it's not ready yet, but the orbit is better. I don't know why. Huh?
Did you wag other side?
I think you gotta wag it better. I don't know, that may be better. Look at that. What do you think? Huh? Very narrow pedicle. Very narrow. This may be a 5.5 screw. Let's see. Tuck here. Let's see where that is. Shot. That should be right on the money. It looks low. Alright. Let's go pedicle finder. Mallet. So the nice thing about this is I can actually see the pedicle. Shot. That looks good. It's very tight. So her pedicles are extremely abnormal. Shot. There's going to be probably a 5.5 screw if you have one. You guys have 5.5, right? Yes. It's terrible. She got abnormal pedicles, very abnormal. Shot. I mean, shot. Again, it's just very slow, which is fine. You want to make sure you don't split the pedicle if you can avoid it. The tools we're using are the best in the biz. I don't want that going through the end plate, so I'm going to angle it down a little bit. So far. Shot. Yeah, it's taking me to the same place. Shot. So even if I go by cortical here, it's fine. There's going to be a 5.5/40. I think it's just a wag. So I need a 4.5 tap. I'll take a 5.5 tap if you don't have a 4.5 tap. Yeah. Is this the tap? 4.5 tap? I'm going to try to tap it south and medial. Shot? Yeah, it's better. See that? Shot? That looks good. Huh? Ball tip? I feel bone all the way around the tip, so it feels good. Again, we're just using a very small, narrow screw.
Yep.
So I don't have a choice. If I go with a bigger screw, I'll bust the pedicle right open. So I have to use a narrower screw. Feels like good purchase. Shot. That looks good. Suck. Drill. All right. Definitely some challenges on this case where we've been challenged with the pedicle as well as, let's have the pedicle finder, as well as the L4-S1 disc space being completely collapsed and inaccessible. Shot. All right, looks good. This pedicle, let's see if it's as bad as the last one. Shot. It is, but I think we might be able to get, and what do we do, a 5.5? Maybe able to get a 6.5 in this one. Any questions?
Yes, we have a question from Meowasaurus once more on YouTube. And they ask, why do you prefer a TLIF compared to a PLIF?
TLIF is a safer, better procedure than a PLIF. PLIF, you're going on both sides, you have twice the risk of injuring the nerve roots, and there's no benefit to a PLIF. PLIFs don't give better results. They just increase the cost of the surgery, and they, I'm thinking 6.5, 45? 6.5 40. What did we do last time? 5.5 40? Maybe a 6.5 40 on this one. Tap. So 5.5 tap. Is that a 5.5 tap? I need a 5.5 tap. That's a 4.5 tap, isn't it? Oh, 5.5? Yeah, PLIFs were the original surgery before TLIF back in the 90s. And you had to put a cage on both sides. There's absolutely no reason to do that. It doesn't help the patient at all. If you do a good TLIF, you're fine. You're going to get better results than PLIF. Beautiful. Feels great with the ball tip probe, no breach. Shot. All right, Berndes. We need 30 minutes, maybe 35. Yeah, great purchase here. Really good purchase. Nice bone. Nice. This will be a nice, strong construct. It will hold her spine together nicely. All right, last two screws at S1. What other questions do you guys have there?
We have a question from Sunil from on Facebook,
Hello, Sunil.
and they ask, what kind of surgery is this?
This is fusion. Lumbar's decompression, realignment, and fusion. This is what you try to avoid by having the Duke laser disc repair. Unfortunately, this patient, she actually chose a fusion, and so we're honoring her request. All right, let's get a shot. It looks pretty good. Pedicle finder. So we're just about 3/4 of the way done. Shot. Now a lot of surgeons at this point will try to go bicortical, meaning put the screw out the other end of the bone, which I typically like to do. Anything on your waveforms? We're at 5-1 left. Quiet. That's always good. So I'm going to try to break out the front shot so I can get really good purchase. I mean, right here I'm at 4. That felt good. So you see how I broke out through the front? That's called bicortical. We do that when we want like really strong screws. I would say it's going to be a 35 sacral and probably 6.5 35. 5.5 tap. No EMG shot. Shot. What did I say? 35 or 40? I said 35, right? And we've been putting in 40s. I think 40 is probably, sorry, 35 is good. Yeah. I want to come out the other end. Where is the hole? Oh. Feels really good. I feel bone all the way around. So I feel like I'm in that pedicle cylinder. Shot. It looks good. Aiming for my breech. Shot. When you put these screws in, you don't want to wobble this too much because mallet, if you do, I can feel the compression right now at the front. That looks good. All right. That's good actually. So we're right at the cortex. I could have put a longer screw, but I'm happy with the purchase. Purchase is how the screw feels in the bone, by the way, in case you're wondering. All right. This is going to be a hard one. Shot. That's a little high. Right about there. All right, pedicle finder. A lot of people don't know that I do fusions. My patients, many of them don't realize I've done many fusions over the years, and I don't like doing them, but sometimes you have to. Shot. What is happening here? Luis, what is happening here? Right here.
I don't see what, like the battery is falling
I
out?
think it's coming out.
Can you,
falling to the side.
somebody help? Yeah, don't touch it. It's just the battery. Can you double check?
In this?
Yeah.
Do you not see it falling
Oh,
down?
I'm sorry. No, I didn't. I see it now.
Let's get it fixed.
I'm just gonna
Pull it back up, please,
Like that. You know what I'm saying? There you go.
without moving my headlight.
Sarah, I might need something else to make this more secure.
Henry, your battery thing is not good. I
Is-
told you gotta have zip ties.
Yes, sir. Want me to come in and help out?
You guys have the other headlight?
Is it okay?
You guys have the other headlight?
Yeah.
All right, let's take this one off. Grab the other headlight.
In Europe.
Okay.
I just tied it a knot. I'm
No,
sorry.
don't worry about that. Just remove the entire headlight.
Okay.
Yeah.
You need to loosen
You need a step. Can you help Omar? Thank you.
loosen the two wheels.
And
Yep,
then just-
and the top one.
Yeah.
And now lift it straight off.
Yeah.
Straight off. Up and off.
And so if we can save that cable.
You have to open up my
Yeah.
back. Take it out. Why is it warm in here?
So
Go ahead and grab the
How can I reach in?
yeah.
battery.
We can save that cable of the battery, okay, and then connect it to that one.
I can't. How could I reach in and not?
You have to put your hands inside.
Well, I don't want to make him unsterile here.
Reach inside.
You're good.
Yeah, grab the headlight battery. Lift it up. It's just connected there to the side. Okay, it should take you 5 seconds.
I'm sorry, it's stuck on something.
No, it's clipped onto my side. Grab it and lift it.
knobs are too short. Can't find it. I don't know why it's not coming off. Thank you.
And then you'll see the battery cable.
Yeah.
Don't aim it.
Yeah, can you lower the light? Lower the light.
No, your hand is closer. You see the cable of the
Yeah,
battery?
it's attached to the.
Yeah, so just disconnect it right there in the middle.
Duke laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Duke laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Duke laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Duke laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Duke laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Duke laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Duke laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Duke laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Duke laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Duke laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Duke laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Duke laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Duke laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Duke laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Duke laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Duke laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Duke laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Duke laser disc repair, there is no damage to the muscles. The Duke laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Duke laser disc repair. Spinal fusions have a high risk for infection. The Duke laser disc repair has a very low risk for infection. In the 7 years the Duke laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Duke laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Duke laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Duke laser disc repair. In fact, most Duke laser disc repair patients experience improved mobility after the surgery. The Duke laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Duke Spine Institute. With the highest published success rate of 95%, the Duke laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
All right, we're just finishing up a lumbar decompression and fusion, and our patient had 2 bad discs in their lower back which were causing back pain and pinching the nerves going in her right leg, so she had weakness bringing her foot up. We just went in and unpinched those nerves and tried to correct her flat back deformity. What a flat back deformity essentially is, let me borrow that model in front of you. The spine is supposed to have a nice curve in the lower back, a curve backwards. When your discs collapse because they dry out and they get injured, your spine goes straight at that segment that's you're treating. So you want to recreate the lordosis or curvature. The way you do that is putting in spacers, taking out the bone in the back, called an osteotomy, and then of course some doctors will actually compress on their screws and rods, which I don't do because that's known to loosen them and increase the risk of failure. So I don't do any compression. Instead I do osteotomy. Anyway, surgery went very well for her. We finished around 12:15. We expected to finish at 12 noon. We were about 15 minutes late, and that was probably because of the technical issues we had with the camera. I had to take it off and scrub out and scrub back in, so that added 15 minutes to the case. So we would have finished exactly on time. The surgery took us around 3 hours to do, and the patient will recover here at the center for about 2.5 to 3 hours, and then she's going to go home. So this is outpatient surgery. We do it same day discharge. There's a lot of things that we do here at Duke Spine that control the patient's pain so that they don't have a lot of pain after surgery, and that way we can do outpatient spinal fusions. We're probably the first outpatient center in the world to do multi-level lumbar fusions. That means more than one level. We've been doing them for 10 years and even published our outcome data in the past at meetings related to the spinal fusions being done outpatient. Today's case went very well. I didn't have any problems. We just couldn't get a cage into the bottom disc because it was so collapsed. That said, everything else went very smoothly. All right, what questions do we have?
No current questions, but we do have a few comments. Just one from Allison on YouTube that says regards from Brazil, and we just had Derek Olson confused about the sound at the very end, but I reassured him. Other than
Yeah, I
that,
apologize on the sound at the end. I actually took off my headgear, which had the mic on it, so we just went for the last 20 minutes without sound. That's why we give you guys the opportunity to type your questions here. Anyway, we're going to wrap this broadcast up. Next, we're going to be back for a Duke Laser disc repair in about, an hour.